Welcome to PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons. It's greatly appreciated. In this video, we're going to discuss the actions you should take when PFT values have higher than expected z-scores and percent predicted. This case is about a patient undergoing spirometry testing, but the principles I'm going to review apply to other tests as well. This is the flow volume loop from a patient I tested, and it looks pretty good. No obvious errors. And this particular measurement had no errors. It passed all of the ATS-ERS acceptability criteria. And test repeatability scores were A for both FVC and FEV1. However, what captured my attention was the fact that the z-scores for FVC and FEV1 were above the upper limit of normal, with z-scores higher than 2. The percent predicted were also on the high side at 151 and 38%. We use a z-score of minus 1.64 as the lower limit of normal, and a z-score of plus 1.64 as the upper limit of normal. So according to the empirical rule, 90% of values recorded from patients with normal lungs should fall between the lower and upper limit of normal. The patient in this scenario has z-scores higher than 2. This should only occur in 2.5% of patients. Certainly not impossible, but unusual enough to justify taking additional steps to verify the accuracy of the data. Let's review some of the things we should verify when values are unusually high. It is obviously important to verify that the date of birth is correct. If a patient is 18 but the age entered into the PFT software is 8, the z-scores will be inaccurately higher. It is also important to make sure that the born sex is correct. Our software has birth, sex, and gender as separate demographics because they are not the same thing. It's the birth sex and not the gender that determines adult lung size. As an example, this is a study we had published in Respiratory Care showing that if female gender was used as birth sex in born males, the percent predicted became significantly higher both for FVC and FEV1. The other important demographic to verify is height. If we record and enter a height lower than the correct height, the z-scores and percent predicted will both be inaccurately high. As I mentioned in my video about height measurement, stadiometers may not be accurate and should be checked for accuracy periodically with a measuring stick for QC. There are some patients in which standing height can be misleading. For example, if a patient has significant kyphoscoliosis, the standing height may give a misleading view of what their lung size should be, and their z-scores and percent predicted will be inaccurately higher. For these patients, arm span can be used to predict what the standing height would be in health. However, the relationship between standing height and arm span is not one-to-one. However, your PFT software should be able to make the proper calculations. Measuring arm span may also be difficult, especially if you're alone and you're trying to measure this with a tape measure. Some patients may not be able to straighten their elbows or lift their arms due to shoulder issues. So the other method to use is the ulnar length, shown here, which is actually more accurate than arm span, and it is the recommended method for young children. Calipers are recommended over a tape measure, and just like arm span, your PFT software should be able to convert the ulnar length to height. Lastly, although this is unlikely to happen, you may want to verify that the reference equation is correct. I do remember hearing about a technologist that would change the reference equations without telling anyone. More likely than that is sometimes software upgrades can cause problems, so it's never a bad idea to verify. The other issue to be aware of is if you've adopted the GLI global race-neutral equations for spirometry, the z-scores and percent predicted will shift higher for Caucasian and Northeast Asian patients since the predicted value is lower than the race-specific value. Let's shift gears and discuss some technical problems that may shift values inaccurately higher. One of these potential problems is an inaccurate room temperature in the PFT software. We mount digital thermometers close to where the technologist is sitting, so it's quite visible. Temperature is important because it affects the BTPS correction factor that is applied to the recorded spirometry values. So I'm sure you're all familiar with this table, but sometimes we forget about the fundamentals. All spirometry values are reported at body temperature and atmospheric pressure saturated with water vapor, or BTPS. Since the room temperature in the spirometer is lower than body temperature, the recorded value is multiplied by the BTPS factor to make this adjustment. So at 37 degrees, there is no adjustment to be made because that is body temperature. But as the temperature goes lower than 37 degrees, the adjustment gets larger and larger. In the data that I showed, the room temperature was 22 degrees C. So the BTPS correction factor is 1.091. So if the recorded FEV1 was 3 liters, the reported value would be adjusted to 3.27 liters. So if the temperature in the PFT software is reading falsely low, like 17 degrees C, the BTPS correction factor will be large and make all of the reported values inaccurately higher. Obviously, one of the most important things for us to verify is the accuracy of our flow measuring device. In this case, we were using a pressure differential pneumotachometer that measures the pressure across a metal screen. So if the distal pressure port, colored in blue, is not seated properly, the pressure differential across the screen may be higher, leading to inaccurately higher values. With these pneumotachs, the screen itself can be a problem. If the resistance across the screen increases, the pressure differential will increase also, and the recorded values will be falsely high. We blow compressed air through the screens every morning to prevent the buildup of shards of filter material. In this case, I opened up the pneumotach, took the screen out, held it up to light to make sure it was clean. The other problem is that condensation can build up on the screen as shown in the right panel. This was more of a problem with the older unheated models, but it can still happen with the heated pneumotach if the room temperature is kept too cold. So if someone likes the AC on and they get the room temperature down to 20 or less, this can absolutely happen even with the heater in place. Now, many of you probably don't use this pneumotach, but if you use a disposable pneumotach, you can just replace it with a new one if you suspect that a problem is present. This is an example of what happened when we had a pneumotach screen that was saturated with water. You can see this tremendous bronchodilator response with the peak flow that goes off the screen. This looked funny to me and opened up the pneumotach and did find that there had been water buildup on the screen. After I removed all the condensation from the screen, I repeated the post-bronchodilator spirometry. You can see the values are very different. The error in FVC would have been over a liter, and the FEV1 error was 900 mLs. So it's always important as a technologist to be suspicious and a little paranoid when things don't look quite right or too good to be true. Another technical problem that can result in inaccurately high values is a positive zero flow error. So that means when the pneumotach is measuring expiratory flow, even though there isn't any flow. As you can see on the right panel, everything is drifting upwards even when the patient's not on the mouthpiece. So if you suspect this, it's usually easy to fix. You can just re-zero the pneumotach. And of course, the other thing that we can do to verify the accuracy of our spirometry results is just repeat the calibration verification, which I did in this case. So I had calibrated it first thing in the morning, but as you can see on the screen, this occurred around 10 o'clock in the morning. So calibration is not just for breakfast anymore, as I like to say. Whenever I suspect a problem, I will take out the cal syringe and do a cal verification and make sure things are still operating okay. And you can see that all of the values are within the expected range. This table shows the 2 cal verifications that I performed on this day. As you can see, there is no difference between the 2 cal verifications, so that doesn't support the idea that an inaccurate spirometer is making the patient's recorded values higher. This isn't probably the first thing you do, but you could also repeat a BioQC measurement, which I did here on this day, and you can see that the highlighted data point is close to the mean within 2 standard deviations for this device. You can also go back and look at historical data, and as you can see here, the patient had a previous spirometry 7 years earlier. Her numbers are pretty similar. Because she's aged and maintained the same raw values, her percent predicted have gone up. As I covered in another video, some patients will have a long torso, short legs body type, and those patients may have higher z-scores and percent predicted because based on their height alone, you would expect smaller chest dimensions. That wasn't the case for this patient. She had a balanced body type. She just has big lungs for her stature. If you think back to the bell curve that I reviewed, these types of values should only be seen in 2.5% of cases, but someone has to be that 2.5%. The same thing applies to the other side of the bell curve. You may see a seemingly healthy patient with values just below the lower limit of normal. That should only happen in 1 in 20 cases, but someone has to be that 1 in 20. Lastly, when you come across one of these situations, it's a good idea that you document that you verified that the data is correct. not just for the doctor interpreting the test, but for others who may review the results in the future, possibly at a different location. Key points: be suspicious whenever PFT values are higher than expected. Demographic errors may create erroneous z-scores. Technical errors should be ruled out. These include BTPS, correction factors, temperature measurements. Make sure there's not a positive zero flow error. Always investigate whether the flow sensing device is working accurately. You can verify functionality with calibration verification and BioQC. Keep in mind that sometimes high values are physiologic, and always document that the data accuracy was verified. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.